My task today is to discuss the role of surgeons in the management of oropharyngeal cancer. In my experience being the head and neck consultant in our institution, I can see two possible scenarios when presented with this. It's either the patient first came into your service department or the patient came in as a referral from other specialty department. General surgeons rarely encounter this type of case, and if ever they do, they would tend to refer the patient immediately to the specialty institutions. But what can you do as a general surgeon if you want to go the extra mile? So my job today is to walk you through the thought process of how to approach and manage this case as a general surgeon. In the initial assessment, there are several questions you need to answer. What is the immediate surgical concern? Is there an impending airway obstruction? Is there bleeding? What does the patient want? In my experience, what the patient wants depends on what he understands about his current problem. If you look at the profile of this type of patients, they usually come from the low income bracket and low level of education. Fear or ignorance, or both, are the common reasons for them to seek late consult. As the surgeon, your role is to educate them of the possibility of a malignant process and its natural course or complications if left unmanaged. Once the patient understands his condition, then you can lay down your plan. In this particular case, I will enumerate 3 important goals for you to accomplish as the general surgeon. These are airway management, access to nutrition, and histologic diagnosis. Tumors of the oropharynx, especially those that are huge and friable, pose a serious risk for the patient. Your immediate concern as the general surgeon is to secure the airway based on 2 premises. First is to protect the airway for the possible or impending obstruction or aspiration secondary to bleeding, and second, to facilitate accurate assessment and safe biopsy without fear of aspiration from bleeding. Will you insert an orotracheal tube or tracheostomy tube? In this particular case, there is little argument that the best way to secure the airway is by placing a tracheostomy tube. As a general rule, you may do orotracheal intubation in cases of urgent airway protection and later convert it to tracheostomy. This patient will be on protected airway for the duration of his treatment, and data have shown that prolonged translaryngeal intubation will not only compromise the vocal cord, but will also cause other problems related to prolonged intubation. There are several reasons why we prefer tracheostomy over endotracheal intubation, as shown in this table. Here are some to name a few: reduced laryngeal damage, better pulmonary toilet, easy to clean and declog the obstruction or mucus plug by just removing the inner cannula, improved patient comfort, better oral hygiene, and improved ability to talk, especially if you use the fenestrated type. Orotracheal intubation, on the other hand, is preferred when you need rapid initial placement of airway device. Although tracheostomy has more advantages than orotracheal intubation, please bear in mind also that it has its own share of complications. Depending on the time of occurrence, complications of tracheostomy may be divided into immediate, delayed, and late. The most common immediate complication encountered is hemorrhage. Superficially, this can be due to the anterior jugular vein from the strap muscle or from the inferior thyroid vessels deeper into your dissection. Delayed complications usually occur more than 24 hours post-tracheostomy and can manifest as secondary hemorrhage, subcutaneous emphysema, mediastinal emphysema, or delayed tracheoesophageal fistula. Commonly encountered late complications are laryngeal stenosis due to the damaged cricoid cartilage from high-lying tracheostomies, and tracheal stenosis secondary to pressure necrosis of tracheal cartilage. Another late complication is tracheoinnominate artery erosion. Although quite rare, this is the most feared complications of tracheostomies and is worth taking into consideration. The vast majority of cases, approximately 75%, will occur within 3 to 4 weeks of tracheostomy placement. The mortality rate approaches 100% even when surgical intervention is undertaken. Risk factors would include excessive movement of the tracheostomy, high pressure or overinflated cuff, or a tube that has been placed too low. The innominate artery lies adjacent to the trachea and crosses that structure at approximately 9th tracheal ring. So here are a few tips and precautions when doing tracheostomy in order to avoid such complications. Immediate and delayed complications can be prevented by doing a good surgical technique and knowledge of the anatomy. Late complications, such as tracheal stenosis, can be prevented by using the appropriate tube size and avoiding pressure necrosis. And in cases of laryngeal stenosis, avoid injuring the cricoid cartilage, which usually occur in high tracheostomies. Subcutaneous emphysema can be prevented by avoiding tight skin closure to allow for leaked air to dissipate outside instead of accumulating into the subcutaneous tissue. Erosion into the tracheo-innominate artery can be prevented by appropriate tube size and cuff pressure and avoiding tracheostomies below the 3rd tracheal ring. What type of tube will you use? There are so many variety of tracheostomy tubes in the market, depending on the brand, the type of material used, whether they are fenestrated or not, presence or absence of cuff, presence or absence of inner cannula, and some specially designed tubes. This variety can sometimes become a disadvantage to the patient if the surgeon is not familiar with them. The goal here is to choose the appropriate tube for the patient in order to maximize its benefits and lessen the chances of tracheostomy complications. So let's discuss a few basic information about tracheostomy tubes. I am more familiar with Shiley brand, so my presentation here is biased on its favor. This diagram illustrates the basic parts of a standard Shiley tracheostomy tube. You have the flange, outer cannula, inner cannula, obturator, cuff, the pilot balloon, and the fenestration. Flange is the part that is attached to the outer cannula. It provides holes for securing and stabilizing the tube. The tube specifications are coded and printed on this part. You can read here the size, cuffed or uncuffed, fenestrated or non-fenestrated, the inner diameter, the outer diameter, and the brand. This is an example of codes printed on the face of the flange. Familiarize yourself with the size by checking the inner diameter or ID printed on the flange. The outer cannula forms the body of the tube. It can be either fenestrated or non-fenestrated. The outer diameter is measured based on the outer cannula. The inner cannulas fit into the outer cannula either by twist and lock or push and clip. These can be either washable or disposable depending on the brand. Its advantage over single cannula tube is that it can be easily removed for cleaning without disrupting the outer tube. It has an optional fenestrated cannula. The inner diameter is measured based on the inner cannula, not on the outer cannula. Obturator. This simply serves as a guide in inserting the tube. Cuffs serve to maintain a protective seal around the tube to stabilize it and protect the airways from aspiration. Modern cuffs are high volume and low pressure, thus preventing pressure necrosis on the tracheal mucosa. It also serves to prevent the tube tip from eroding the tracheal lumen. Pilot balloon serves as an external indicator that the cuff is inflated. Fenestration is an optional feature that allows air to flow through the vocal cord and facilitates speech. Depending on certain situations, manufacturers like Shiley have specially made non-standard tubes with varied distal, radial, or proximal lengths. Long proximal lengths are prescribed for thick necks. Long distal lengths are used to bypass a tumor or stenosis obstructing the tracheal lumen. Some brands, such as Portex or Bivona, offer adjustable flange to adjust the proximal or distal length of the tube. Now let's talk a bit about tube sizes. Here are some basic information before choosing the appropriate tube size. The trachea is between 9 to 15 mm in diameter in the adult. An adult male trachea will generally accommodate an 8 to 8.5 mm inner diameter tube. The adult female may prefer a 7.5 mm inner diameter tube. A tube that is too small may result in the need to overinflate the cuff, increasing the risk of pressure necrosis. The tube size is based on the inner diameter measured in millimeter. For dual cannula tubes like Shiley, the inner diameter is based on the inner cannula. Unlike Shiley, the newer brands are single cannula tubes. The inner cannula is optional and disposable and not included in the sizing. Look for the inner diameter measurement in choosing the tube, whether it's dual cannula or single cannula. For brands other than Shiley, if you insert the inner cannula, the functional inner diameter will decrease by 1 mm. This table gives you a rough guide on what size to prescribe based on the patient's age. Shiley brands and metallic tubes have a different sizing based on Jackson sizing system. Newer brands use the ISO method of sizing determined by the inner diameter of the outer cannula. Shown in this table is the range of sizes based on your preferred brand. Notice the sizing difference between the standard Shiley and the rest of the brands. As explained in the earlier slides, the inner diameter of Shiley brand is based on its inner cannula. The rest of these brands are single cannula tubes. That's why their sizes match their inner diameter. Disposable inner cannula is not included in the sizing. The important thing in choosing the tube is to look for the inner diameter measurement. Choose your own brand. In my case, I prefer Shiley. Your second role as the attending surgeon is to gain access for nutrition. The specifics on nutrition is beyond the scope of my lecture, but suffice to say that we cannot overemphasize enough its importance to head and neck cancer and cancer in general. Malnutrition and nutritional deficits have a significant negative impact on mortality, morbidity, and quality of life. Approximately 35 to 60% of all patients with head and neck cancer are malnourished at the time of their diagnosis. 3 factors contribute to malnutrition in head and neck cancer patients even before they start their treatment: diminished nutrient intake, increased nutrient demand not matched by intake, and tumor-induced derangements. Swallowing problem is the main culprit for the diminished nutrient intake in head and neck cancer patients. This is where your role as a surgeon comes in. These 2 factors are inherent to the disease process and you cannot control that. Treatment options for head and neck cancer include surgery, chemotherapy, and radiation therapy. Each of these interventions has side effects that may further lead to swallowing problems and eventually contribute to malnutrition. So again, the main culprit for the diminished nutrient intake in head and neck cancer patients prior to treatment, during treatment, and after treatment is the swallowing problem. Therefore, in this particular case, we need to preempt this challenge by forcing the patient to take in food through tube feeding. What type of tube feeding will we do in this case? The usual options will be NGT versus the convenience of PEG, and most physicians and patients would prefer the latter. Let's look at the data comparing both approaches. In this Cochrane review by Gomez et al., they evaluated the effectiveness and safety of PEG compared to NGT in adult patients with swallowing problems. Their primary outcome measure is intervention failures, defined as an event leading to failure to introduce the tube, recurrent displacement, and treatment intervention failure, such as leakage or clogging of the tube. And their secondary outcomes include adverse events and quality of life, among others. This plot shows that PEG was associated with a lower probability of intervention failures, suggesting the endoscopic procedure may be more effective and safe compared with NGT. This plot, on the other hand, shows no significant difference between comparison groups in terms of adverse events. But further sub-analysis shows pneumonia and reflux esophagitis to be of lesser occurrence, thus favoring PEG. Quality of life outcomes in two studies with 133 participants illustrate this plot favoring PEG over NGT. Fewer participants found the intervention of PEG to be inconvenient, uncomfortable, or interfered with social activities. However, there were no significant difference between two groups for pain and ease of learning to use. The outcome of mortality and nutrition doesn't seem to differ between PEG and NGT. Now, this one is easy. Your final goal as the general surgeon in this particular case is to answer the question, what is the histologic diagnosis of this case? To facilitate that objective, you need to have a thorough assessment by palpating the mass and locating the best site for biopsy. But in doing so, you run the risk of possible bleeding and subsequent aspiration. Securing the airway will facilitate safe biopsy and management of complications such as bleeding and aspiration. When do you perform the biopsy? The best time to perform this is right after you inserted the tracheostomy tube while the patient is still in the operating table. You can do this either by local anesthesia, sedation, or under GA. OPD procedure is optional. The important thing is to have the proper instrument. Invest on a good quality punch biopsy. I use this one all the time. The cut is small and there is lesser bleeding. Do I perform biopsy in all of my head and neck cases? It depends. In my practice, especially charity cases, I only do the biopsy once the patient is fully aware of the following: the natural course of the tumor if left untreated, the purpose of doing the biopsy, and the treatment plan depending on the histopath result. If the patient refuses to be subjected to the recommended protocol treatment, then usually I do not perform the biopsy. I do not force the patient as long as he or she fully understands the consequences of his or her decision. So in summary, you are presented here with an oropharyngeal mass in a 62-year-old male patient. Being a general surgeon does not limit you from doing what the head and neck surgeons would do in this particular case. Three important goals for you to accomplish as the general surgeon in oropharyngeal cancer patients are the following: airway management, nutritional access, and histologic diagnosis. A thorough knowledge of the disease process and patient education is an important tool you need to have in order to accomplish the above goals and contribute your part in the multidisciplinary management of head and neck cancer patients. Thank you for your kind attention.